Hello everyone. In this class, we'll briefly learn about posterior pituitary. Posterior pituitary releases two important hormones, that is oxytocin and antidiuretic hormone. Oxytocin, it is synthesized by a paraventricular nucleus of hypothalamus and it acts on myoepithelial cells of mammary gland and the uterus. Actions of oxytocin on mammary glands. It causes ejection of milk from mammary gland. Oxytocin causes contraction of myoepithelial cells. It squeezes milk from the alveoli to the exterior through the duct system on nipple. The process by which milk is ejected from the alveoli of lactating breasts is called as milk ejection reflex. So this is the milk ejection reflex, that is suckling of the breast causes stimulation of the stretch receptor, which is through the vagus. It is going to cause the stimulation of paraventricular nucleus and it causes secretion of oxytocin, which is released in the posterior hypothalamus, and thus released oxytocin in the blood reaches the myoepithelial cells of the breast tissue and causes contraction of myoepithelial cells, and it leads to ejection of the milk in the mouth of the baby, which is called as milk ejection reflex or milk let down reflex. On the uterus, on the pregnant uterus, it causes contraction of the smooth muscles of uterus and helps in the expulsion of the fetus. Sensitivity of the uterine musculature to oxytocin is enhanced by estrogen and inhibited by progesterone. In late pregnancy, the uterus becomes very sensitive to oxytocin due to the increase in the oxytocin receptors, and oxytocin secretion is increased during labor. At the onset of labor, cervix dilates and fetus descends through the birth canal, and expansion of the birth canal stimulate the stretch receptors. From them, impulses goes to the pituitary through the afferent fibers, which in turn increases oxytocin in the blood. This will reach the uterus through general circulation, and this enhances further strong contraction of the uterus and favors delivery of the baby. On non-pregnant uterus, oxytocin acts on the uterus to facilitate the sperm transport. Oxytocin released causes uterine contraction and facilitate sperm transport. Other actions in males, at the time of ejaculation, it causes increased contraction of the smooth muscles of the vas deferens and helps in propelling the sperm towards the urethra. So this is the diagram showing the parturition reflex, increased estrogen and progesterone ratio, and causes increased contractility of the uterine muscles. The growth of the fetus and descent of the fetus causes increased stretch of the uterus, increases the uterine contraction, increased pressure on the fetal head on cervix. Then nerve system communicates with the posterior hypothalamus, and there will be increased oxytocin release that increase the uterine contraction, and that becomes a vicious cycle and it leads to parturition reflex. Another hormone secreted is vasopressin, which is also called as antidiuretic hormone, secreted mainly by the supraoptic nucleus of the hypothalamus. It is antidiuretic hormone, and it has different receptors, vasopressin receptors V1A, which are located in the blood vessels, liver, and brain. There are also V1B receptors, which are also called as V3 receptors, located in the anterior pituitary, and V2 receptors, they are mainly located in the kidney. The actions of vasopressin they are important for water retention. The major function of ADH is retention of water by acting on the kidney through the V2 receptors. The main site of action is at the distal nephron. It increases the permeability of the collecting ducts of the kidney. Due to the increased permeability of water, the water enters hypertonic medullary interstitium. Thus, diuresis is prevented. Water is retained in the kidney and urine becomes concentrated. Water is reabsorbed through the aquaporin 2 channels, which are ADH responsive water channels. So whenever there is increase in the osmolarity, or when it becomes hypotonic, it stimulates osmoreceptors which are present in the supraoptic nucleus. Then there will be secretion of ADH, which causes water reabsorption, and tonicity of the fluid is restored. And whenever there is a decreased osmolarity, osmoreceptors are inhibited, supraoptic nucleus is inhibited, ADH is not secreted, so water is excreted in urine and the tonicity of the fluid is restored. So, or whenever there is a decrease in the volume receptors present in the great veins and atria, they are less stimulated, then it causes the third center to be stimulated, and SON is less inhibited. So there will be more increased intake of water, and ADH secretion is going to increase. That increases the water from DCT and DCD to be reabsorbed, and ECF volume is restored. So whenever there is increase in the volume receptors are stimulated, the thirst center is inhibited, and SON is inhibited, and ADH secretion is inhibited, which causes no absorption of water from DCT and CD, and the water excretion increases, so the ECF volume is going to be restored. Vascular effect. In large amounts, ADH causes vasoconstriction of the vascular smooth muscles, which are mediated by V1A receptors. Due to the vasoconstriction, blood pressure increases. The other actions of vasopressin, they act on the anterior pituitary and cause ACTH release, which are mediated by VNP receptors. It is a neurotransmitter in brain and the spinal cord as well. Vasopressin causes glycogenosis in liver, which are mediated by V1A receptors. Regulation of ADH secretion, it occurs by two important factors, that is osmolarity and the ECF volume, as we discussed through the charts. The other stimulants of ADH are pain, emotion, stress, exercise, vomiting, and angiotensin II. And some of the inhibitors of the ADH secretion are alcohol. Some of the clinical aspects: patients highly sensitive to vasopressin are prone to hypertension. In massive hemorrhage and shock, vasopressin is secreted in high amounts, and the pressure action of the vasopressin raises the blood pressure. Diabetes insipidus. Diabetes insipidus is the deficiency of ADH, and this disease is characterized by excessive secretion of water through the urine, that is polyuria, and increased water intake, that is polydipsia. Some of the causes are, it can be due to failure of production of ADH, so which is called as central diabetes insipidus, or it may be due to the inability of the kidneys to respond to ADH, which is also called as nephrogenic diabetes insipidus. Central diabetes insipidus, as we know, it is due to the inability of production or release of ADH from posterior pituitary. It can be caused by head injuries or infections, or it can be congenital. Because of the distal tubular segments cannot reabsorb water in the absence of ADH, this condition is called as central diabetes insipidus. Results in formation of large volume of dilute urine with urine volumes that can exceed 15 liters per day. The treatment for central diabetes insipidus is administration of synthetic analog of ADH, desmopressin, which acts selectively on V2 receptors to increase water permeability in the late distal and collecting tubules. Nephrogenic diabetes insipidus. This condition, there will be normal or elevated levels of ADH, but the renal tubular segments cannot respond appropriately. So this condition is referred as nephrogenic diabetes insipidus because the abnormality resides in the kidneys. This abnormality can be due to either failure of countercurrent mechanism to form hyperosmotic renal medullary interstitium, or failure of distal and collecting tubules and collecting ducts to response to ADH. In either case, large volumes of dilute urine are formed. Many types of renal diseases can impair concentrating mechanism, especially those that damage renal medulla. Also, impairment of function of the loop of Henle, as occurs with diuretics that inhibit electrolyte reabsorption by this segment, can compromise urine concentrating ability. The treatment of nephrogenic diabetes insipidus is to correct the underlying renal disorder. The hypernatremia can also be attenuated by low sodium diet and administration of diuretic that enhances renal sodium excretion, such as thiazide diuretics. This is in brief about posterior pituitary. Thank you.